Ladies and gentlemen, welcome to today's gastrointestinal oncology thematic session. Before we begin, let me introduce our three distinguished conference chairs. Professor Yanxi Liu from the first affiliated hospital of USTC. Professor Feng Shen from the third affiliated hospital of the Naval Medical University. And Professor Joseph Lovett from the Icahn School of Medicine at Mount Sinai. First, please welcome Professor Yanxi Liu to give us opening speech.
Dear colleagues, ladies and gentlemen, good evening. I'm truly delighted to be here tonight for this conference focused on the long-term, we call it the long-term survival journey for Chinese patients with gastrointestinal tumors. First of all, I would like to express my gratitude to the organizer for providing such an excellent platform. It's beautiful season, I think, for communication, as well as to all the experts to taking the time to attend this conference. In China, there's a large number of patients with gastrointestinal tumor, and their conditions have their own characters. This makes our exploration of long-term survival for these patients both challenging and full of unique opportunities. In recent years, oncology research in China has progressed at a remarkable pace. For instance, we have carried out excellent clinical studies in immunotherapy and targeted therapy, finding gradually into clinical practice and offer patients great hope for improved survival outcomes. In the well-known Himalaya study, dual immunotherapy combination significant such as destiny gastric 04 and the results from China subgroups in these studies are well consistent with the global data. Meanwhile, constantly learning advanced the international blending actual situations and the treatment strategies better suited to Chinese gastrointestinal patients. At this conference, we are truly pleased to have the chance to the latest in gastrointestinal cancer and Professor Lovin, and share our research findings and clinical insights. I believe that such exchange and interactions and dialogue will definitely spare more ideas for improve the level of the gastrointestinal cancer treatment and enable more patients to achieve longer survival time and higher quality of life. I do hope everybody can enjoy the conference. Thank you.
Thank you, Professor Liu, for your inspiring remarks. Next, let's invite Professor Feng Shen to deliver his speech.
Good evening, ladies and gentlemen. Distinguished Professor Joseph Lovett, colleagues, ladies and gentlemen. Good evening, everybody. The ESMO Congress is truly a remarkable event and two of the chairs for this conference. It's a privilege to participate in this profound discussion on the long-term survival path to Chinese patients with gastrointestinal cancers. First, I would like to extend my warmest welcome and deepest gratitude to all the colleagues to take time out of these busy schedules to join us. for this meaningful gathering. ESMO has always played a central role in advancing global oncology. Over the past few years, Chinese scholars have become increasingly engaged in the academic activities of ESMO. So this active participation, we have not only absorbed the latest international knowledge, but also shared clinical insight and research data from China, contributing to the continued extension of survival for patients with gastrointestinal cancer. In the field of gastrointestinal oncology, bigger progress in targeted therapy, antibody-drug conjugated ADC, and immunotherapy has dramatically improved both survival rate and the quality of life for patients. In the Himalaya study, the straight regimen has delivered promising outcomes, helping patients achieve long-term survival. Data from the global cohort shows that 5-year overall survival rate in the straight regimen group reached 17.1%. Notably, this is the only study in the hepatocellular carcinoma field to have achieved 5-year long-term survival, bringing hope for long-term survival to patients with advanced liver cancer. Similarly, the Destiny Gastro series of studies has redefined the treatment landscape for HER2 positive advanced gastric cancer. These advances, along with many others, have been greatly shaped by data and contribution from China, further opening up new treatment options in clinical practice worldwide. This conference represents a critical moment for the exchange of Chinese scientific research achievement with global perspectives. Together, we will highlight the touch moment and a new hope in the treatment of gastrointestinal cancers and explore how to transform the latest scientific breakthroughs into long-term survival. Through this high-level international dialogue and collaboration, we aim to inject a new variety into global diagnostic and therapy management for gastrointestinal cancers, ultimately working toward the grand goal of curing these diseases. Thank you all.
Thank you, Professor Shen, for your wonderful sharing. Finally, please welcome Professor Jose Lovey to give his speech.
Well, thank you very much for the invitation. It's a pleasure to be here. I'd like to thank the chairs for inviting me to co-chair this session. So I'm only expert in HCC. So if I don't discuss anything about gastric, it's because I don't know anything about gastric cancer. You are the experts, so I can share my views about what's going on in HCC. I think we had a first period of TKIs, right? Then second period that has been a revolution, that are immune-based regimes. And here you have today will be, you will be updated about the 5-6 years survival of the stride regime. So what has been a revolution in my view is that HCC at the beginning with the TKIs, despite that we were able to expand survival significantly, there was no option for cure. And now with the immune-based regimes, there is an opening for cure for patients at advanced stage. So what does that mean that we have a 20% survival at 5 years? These patients probably, most of them have either cured the disease or controlled the disease, have cured the disease. So this is outstanding that is happening in advanced HCC. So I would say that this has been a revolution. And the third revolution that now we are envisioning eventually perhaps today will be not the point of the immunotherapies now are moving to early stages. So we have the Emerald-1, we have the Lipo-12, and other regimes that are moving to early stages, intermediate plus stage. Also now neoadjuvant and adjuvant therapies, that it's a field that certainly you need also to explore. So we are envisioning now a very exciting time with a cure of patients with advanced HCC, also opportunity for what is called conversion therapies. A percentage of these patients may eventually receive resection as a conversion therapy in order to secure the curation of the disease. And also, now we are plugging early and intermediate HCC, and this, in my view, it's a major breakthrough also in the management of the disease. So I will be open to the discussion, only the things related to HCC, and I'm very glad to know and to understand the data of the subgroup analysis of Chinese patients in HCC. Thank you.
Thank you very much. Now we will begin our first lecture session. I will now hand over the microphone to Professor Feng Shen to chair.
Now, may I introduce our first speakers in this conference, Professor Stephen Chang, my good friend. And his topic is about new answers in gastrointestinal tumor treatment, focusing on long-term survival needs and exploring the path to breakthrough. Thank you.
谢谢沈院长、沈教授。New answers in GI tumors treatment, focusing on long-term survival needs is exploring the path to breakthrough. So when I see this topic, I see this as a more difficult task than I prepare the discussion for today's abstract. So actually, I do think for a while, what should I prepare to talk about the long-term survivals? And this was my disclosure. And then I prepared this one. I would like to share with you a story about the small print. So this is one of the books that, according to the AI, it was sold very well on the internet. So this, I was told by AI, this book was sold very well about the cancer survivor through faith. Sorry about the small print, you don't need to go through the details. Basically, it's talking about a young lady who became pregnant at high school and then was diagnosed with stage 4 head and neck cancer. And then she needs to undergo surgery, chemo, radiation. And but I think the most important thing about this story is this. Sarah defeated the odds. And probably this is the reason why it was so very well. And I believe this is also the wish of our patients. I'm sure they can go to the internet, they could go to the AI and know the prognosis or the median overall survival of their cancers. But I'm sure if you have seen enough patients, all the patients came to me say, I want to be the exception. I want to beat the odds. So I think this is something that always, as an oncologist or cancer doctor, we would like to help our patients. But then what is the odds? Let's see. This is survival figures in GI cancer. I'm more lucky than Joseph because I can talk about other cancer types as an oncologist. So let's talk about the gastric cancer. If you look at the gastric cancer survival curve, this is the pattern. You can see even with the green part, the chemo plus surgery, the median survival is around 1 to 2 years. And they don't even show anything further beyond 5 years. And then you look at the colon cancer. This is a typical survival curve you will see. And again, sorry about the small print, you can see the survival is something like 2, 3, at most 4 years. And they, again, this time is better. They show something like 6 years survival. But again, they don't show anything further. Then how about HCC? And of course, this is, I think, it's the reflex study presented by Dr. Kudo. But you can see we median overall survival around 1 year, but again, we don't report something beyond 5 or 6 years. So I think that the thing is traditionally, I don't know what will you do in the clinic. When a patient asks me, how long will I live, doctor? And usually I will tell them, oh, you have a chance of living. I usually try to avoid telling them the median survival figure because most of the time they'll be very disappointed. And we do not, or we dare not talk about the long-term survival. And of course, nowadays we know this is not the case, at least from other cancer point of view. For example, for melanoma, the checkmate 067, you can see they're reporting the 10-year, not only the 5 years, but also the 10-year survival figure. And of course, this is likely as a result of not the chemo, not some targeted therapy, but the use of the very aggressive immunotherapy like ipi-nivo. And then you also look at another cancer type, the lung cancer, the checkmate 9LA. I know this is an AstraZeneca meeting. Don't worry, I'm not keep talking about ipi-nivo. But again, probably they're the first one who developed their immunotherapy regimen. But again, you can see, oh wow, I don't know what's the problem. You can see they also reporting something like 5 years or 6 years survival rate. This time is not as impressive as melanoma, but at least we are starting to present some of these data for patients with stage 4 metastatic lung cancer. And of course, nowadays, I think we are in a very historical moment because in ESMO, we are seeing this ESMO poster. For those patients who actually treated with the Chami Durva, and then you can see the curve continue separating. And I think last year, Lorenza and I have presented the 5-year survival data and also published, I think it's in the JHAP. And this year, we are seeing the 6-year survival rate, which is 17.1% versus 8.9%. Is this impressive? I would say so, because although we are a bit late comers, but still we are reproducing data that some patients with advanced HCC, they actually can survive long. And actually the proportion is not that bad, right? 1 out of 5 patients, they can survive like this figure. So today I'm happy to tell my HCC patient, we do have data telling you that 1/5 of chance you can be the kind of survival long, or sometimes I can use a more general acceptable layman term, cure. I'm quite comfortable to use this term because you can see the curve is plateauing. Maybe a bit drop, but I don't think it's due to recurrences, probably due to other problems. So this is the table I would like to summarize. Of course, you don't need to go into details, but I would like to highlight the Himalaya is the only clinical trial that they have reported such a long survival rate and also update. I think this is really phenomenal, and also thank for AstraZeneca for doing that, because we know sometimes pharma, their industry, they are not very keen to keep following a patient because they told me it's actually very expensive to follow the patient for such a long time to keep updating the data. So I would say what's the 3 most important component of long-term survival? I would still say CTLA-4 because you can see all the trials or data that I presented or shared is use of either EP or Chami. So I do think CTLA-4 plays a role. And also we need a relatively immunogenic tumors. Of course, the most immunogenic is the melanoma. But I would say nowadays the lung cancer, HCC, they belong to the same category, that they are responsive to the immunotherapy. But finally, we need to have a safe combinations. We need some combination that they cannot kill the patient from the beginning. In that case, I think Strike is better than the ipi-nivo from the beginning because of the safety profile. And of course, again, I need to show the Lancet Commission. I was told by a China colleague, you need to show a Lancet Commission in every single presentation. This time, I'm not going to show you the 2050 data. I'm going to show you, sorry about the small print, the survivorship in the Lancet Commission. Apart from predicting something in the future, we also care about patients. We already foresee that by 2050, the total number of XCC survivors is projected to increase further. And we do see, because of more early tumor diagnosis, and of course today we have seen the perioperative data, and also the development of more effective sequential treatment, including the strike regimen. So I think in the future, one of the stream or research area that need to focus is the long-term survivors of the XCC patient, which in the old days is more related to the breast cancer or to other melanoma patients. But nowadays, I think this is really important. And this is why we need to pay attention to the quality of life, not only in the initial treatment, but also in the later phase. This is something that sometimes clinical trial may not have kept a record of. And also, of course, is the balance of survival and the toxicity. And of course, this is, I think, more for the 5th year data, but I think strike regimen, we do show that at least numerically, we don't see additional toxicity. This is very reassuring. But I would like to give a challenge to the AstraZeneca team or to our investigator, is that the long-term implication of the toxicity. Numerically, they may not be high, but I do have patients telling me that they belong to the survivors from XCC, but they do suffer some toxicity. Sometimes rash problem, still quite chronic, or sometimes the neurological complications, endocrine complications, psychological. That I think nowadays we probably do not have data to keep record of these toxicity. Look at those long-term implications of toxicity. Usually it belongs to more like endocrine, neurological, sometimes the hepatitis, arthritis, neuropathy. My feeling is probably underreported because sometimes the patient, we don't try our best to keep record of, or basically the clinical trials, we don't have such a long-term monitoring of those toxicities. So I think these are something that maybe we can sit down, think about it. Maybe in the future, we need to have a kind of more long-term endpoint of survivorship follow-up so that we can really know what is the problem that's faced by our survivors. So this is the conclusion. As I mentioned, long-term survival is less studied or discussed in GI cancers, but now it's changing. Focusing on XCC, the long-term Himalaya data show that 1/6 or 1/5 of patients are cured by the strike regimen. And as I mentioned, we need to pay attention to the toxicity, quality of life, and psychological impact of related either to the disease itself, even cured, or the treatment itself. So again, I'm showing the last slide. If you want to discuss more, please go to Hong Kong. Oh, sorry. The most important, because in November, it's a perfect timing. Very chilled, and also you have a very good gamey food, hot pot food in Hong Kong. And more importantly, I do support ELCA, which I think, Joseph, you are the second president, and I will be the president. So I really 需要你们的支持，我们中国的力量。谢谢。
Just a minute. So Professor Chen gave us a wonderful, attractive, and a comprehensive talk. So I believe that a lot of experts to have some questions. So let's move the question and answer. Dr. Tian will, the chair this session. Thank you.
谢谢。
In just a moment, Dr. Tian will have some question.
For me.
The MC first.
It's a very trivial question. It's working? No, it's a very trivial question. When we show this data, the 5-year and 6-year survival of the strike is, as you mentioned, 20% and 70% in 6 years. But it's not possible for me that sorafenib, despite that I was the PI of the trial, have a 5-year survival of 9%. So probably it also would be interesting to understand if this patient received immunotherapy post-progression to sorafenib, because this 9% is very strange, I would say, that is related to sorafenib. So probably these patients were also exposed to immunotherapy. What's your take on that?
But I would like to ask you back about the sorafenib experience. In my experience, now I have two patients. One is a young lady and the other is a young man. They have taken the sorafenib for one actually 7 years, and the other is 8 years. They've never been receiving any immunotherapy. They still survive, and actually it's biopsy proven. I did ask myself, it's really XCC or thyroid cancer, but it's XCC, and they really have a radiological responses. But my belief is because they've been tolerating treatment so well, and also the tumor regressed so significantly, which is rarely seen with the sorafenib. My feeling is there any chance that we trigger on the immunological clearance of the tumor, either by sorafenib or by other mechanism, by Chinese medicine? We don't know. But I agree with you. Maybe there's some patient who received the post-treatment ICI. I can also share one of the data that we've seen with our center is that initially I asked my students to look at the survival of those patients treated with IO first, followed by TKI. And I also look at those older series about those treated with TKI first and then treated with some IO. Initially, I expect them separating widely, but then I found that actually the survival curve is quite close. It's quite close. If you treat the IO first, followed by TKI, or TKI followed by IO, then I understand. Probably the exposure of IO is important, but probably you can also give it after the TKI as mentioned by you. But the only difference is you do lose some patients if they treat TKI first. But if the median overall survival is quite similar. So my feeling is maybe as mentioned by you, TKI followed by IO may be applicable still in some real world that we cannot give IO from the beginning. But I agree. If a patient failed lenvatinib sorafenib, I always push my junior doctor say, try your best to give PD-1 afterwards. Don't give another TKI. Probably push for more PD-1 afterwards whenever possible.
So last year it was announced, and this year was published Checkmate 90W. So Nivo EP3, and interestingly enough, and now I can disclose that I was the chair of the Data Safety Monitoring Committee. And interestingly enough, I mean, if you check the curves at the beginning, the patients are suffering from EP3, and eventually, some cases the patients might die. But when they, are able to overcome this situation, then the outcome is very good. Probably as a result of CTLA-4 on top of the PD-1. So the sense is that the decision making should change if you are using durvalumab or nivo-ipi. So do you want to say something in which what could be the ideal population for nivo-ipi in your mind, as opposed to the ideal population to durvalumab up front?
That's the question that is often raised in all the XCC meeting. How to choose amongst the 3 or 4 regimens. If you are in China, you may have 5 regimens. I have no magic, but we don't have biomarker. But I can share you again some experiences. As oncologists, we do have experience of giving EP for melanoma, for renal cell carcinoma, sometimes for lung cancer. And I can tell you that most of my nasty, horrible IRAE come from EP, high dose. I've seen a patient who told me, "Oh, doctor, the first dose EP, 3 milligram, a bit tired, but okay." I said, "Okay, this is a common side effects of EP." And the second time when the patient came, it's a young patient actually. And then it's the family who told me, "Oh, he seems to be a bit very tired, unusually tired." I say, but then I asked the patient, "Are you okay?" "I'm okay." And then the third dose, the patient become comatose. So turn out this patient encephalopathy, Of course, we managed to save the life of the patient. A very endocrine, we did a neurological input, a lot of treatments, steroids, IVIG, and finally the patient survived. But you can see this can be very debilitating. Of course, the family are not very happy, despite we explaining all the side effects. Another patient is, she complained of bit edema over lower limbs. And then I say, okay, of course we arrange some echo, still okay. But you know, MRI heart is not easy to arrange sometimes. And then I consult our cardiologist, but turned out it's a heart failure, emu myocarditis. My third patient, again, for some unknown reason, neurological is the most horrible. Is the patient did tell me, oh, doctor, I gain fatigue, very tired. And then I was, okay, I say continue, and patient would like to continue. Again, the third dose. Third dose, I think, is a critical moment. And the patient told me, oh, doctors, I have problem going up to the bus. When I go up to the bus, I think, oh, and then I know it's probably some muscle. And then I admit the patient and arrange all the tests and turn out to be a myasthenia gravis. And the patients actually subsequently have some respiratory failure. And all these are EP. I'm not saying that EP is always associated with this, but I think the EP is really high dose. You push all the T cells, and those T cells definitely is more than you can tolerate, at least in the first 1, 2, 3 doses. And then you are bound to see this problem. And whether the patient recover, I think it depends on the physique of the patient rather than your steroid. Of course, steroid you need to give, but finally, we do see patients sometimes they succumb to the toxicity. This is why the curve, they kind of go down much more. I agree with you. I also interpret in that way. So going back to your question is, I will ask myself, if I want to give EP-Nivo, usually first they benefit more from this one, and also they can tolerate the high-dose steroid for at least 4 weeks, 6 weeks. In that case, I think it's more younger patients. And
younger and with very good liver function, I would say. Because if you have borderline patients and they have an autoimmune hepatitis, then eventually if they are border child AB and with autoimmune hepatitis, they may die or have
fully agree.
encephalopathy. Whereas if they are in very good shape or they are not cirrhotic, because in hepatitis B related HCC you have a percentage of non-cirrhotics, then they might tolerate. But all the others, I think that they might tolerate better durvalumab.
I would like to raise one point is actually in the ESCO, if you go back to the video, I came up to the stage and asked one question only. What is the median dose of the EP received by the patient? And then Dr. Gelly laughed and said, oh, Stephen, good question. And then he didn't reply my question. He just say, it's well tolerated, maybe 2 point something. But then I asked him, can you show me the breakdown? How many patients receive 1 cycle? How many receive 2, 3, 4? My feeling is most of the patients only receive 1 to 2. This is also my experience. And then they have toxicity, they cannot begin. And so far, in the paper, in the presentation, BMS has never presented this data. My feeling is probably the patients, most of them, who receive only 1 or 2 cycles. But of course, I may be biased, but this is something that we can discuss together.
An indirect way to sense that is the need of high dose of systemic corticosteroids. That is around 30% with nivo-EP. You show now 17.5 with durvalumab. This is updated.
I think it's updated. Yeah.
So it's 5 years updated. So 70% is very fair.
Thank you. Thank you.
Thank you, Professor Chan, for your meaningful lecture. I also have one question to you.
Okay.
As long-term survival becomes a growing focus in HCC treatment, could you share some memorable long-term survival cases from your clinical experience?
Oh yes, I actually just can share my Himalaya experience. We recruited 33 patients in the Himalaya trial, and turned out 11 patients randomized to Trami Durva, 11 to Durva, 11 to sorafenib. So the randomization really works. And amongst the Trami Durva arm, I think we have 3 patients still alive today. And for the Durva, 1 patient. And sorafenib, of course, no. And I think this quite corresponds to the figure that we have seen. And if you talk about history, there's actually 82-year-old man with a big tumors. And he actually came from China. He was a teacher in China. But in Hong Kong, he worked as a worker. And then he's very nice. He wrote the calligraphy really well. And he responded really well without any problem. Only mild fatigue. And he's still receiving the Durva now in the 8 years. Actually, I asked him, do you consider to stop? No, he said, no, doctor. This is helping me. Because he know that when he stopped, he cannot receive anymore. He said, and then he came back every 4 to 6 weeks to receive the durva. And every time he gave me the calligraphy written by him. So at my office, I have a lot of calligraphy from him. But I think this is exactly the story. We are changing the life of the patient, and they're living with good quality. So thank you.
Steven, I have one more question.
Yes.
Short questions. Yes. So topic is long-term survival. But when we're talking about long-term survivals, after treatment, do you have a number for the patients who received beyond treatment after response?
You mean after initially response, then PD,
Yes.
I continue beyond progression, right? You see,
Not beyond progression, but maybe they have chance to receive local regional therapies or resection.
I have some case series. Actually reported this in JHAP, the oligoprogression. That we are very interested. Of course, we are not surgeons, but sometimes, of course, I do have cases who sometimes a surgeon refuse to resect, but afterwards they learn that after systemic therapy, there's some oligoprogression, they are able to resect. And also, I experience more with TCE or radiotherapy. We have this case series. If we can work together, I'm sure you also have a lot of experience, like those with more oligoprogression, and then you treat with more downstaging or local regional therapy. I think this is something that is also important. I agree with you.
Okay, thank you.
Thank you very much. 谢谢.
Okay, the second speaker is Lianxin Liu. He's a surgeon from China. So he will talk about breakthrough in long-term survival of liver cancer patients from Chinese perspective. So maybe Lianxin will show some Chinese experience, try to promote the number of patients who get long-term survivals. Thank you.
Yeah, thanks, Professor Sun's introduction. And Stephen have given us a lot of experience of long-term survival. Yeah, as a surgeon, I want to introduce some trials to breakthrough in long-term survival of the liver cancer patients from Chinese perspective, especially from the surgeon's perspective. The first things I want to introduce some things of the Himalayas trial, and especially yesterday announced the 6-year overall survival. It's the only trials who reach out the 6-year survival. Yeah, I will introduce this. For long time survival, and it will take a long time to present. Yeah. We just wait. And first I will introduce what is the meaning for the long time survival in Chinese perspective. It's not only living long, but also have a good quality of life for this. And how to get the long term survival is also very important for that. The topic is the breakthrough in long-term survival of the liver cancer patients from a Chinese perspective. And ACC in China is different with the Western countries. It has several immunosuppressed, higher tumor burden and poor liver functions. As we all know, versus other tumors, ACC exhibits a stronger immunosuppressive effect, and for non-virus related ACCs, HBV related ACC is more immunosuppressive and exhausted. And for systemic therapy of the ACC in China, from target therapy, immunotherapy, and target combined with immunotherapy, move to the area of dual immunotherapy. And there's a chart for the regimen which is approved by the United States and by Chinese government. We can see more and more regimens was approved by the Chinese government more than United States. We have a lot of choice. This such as, but for Himalaya, it will launch at the end of this year, maybe the beginning of the next year. And for prolonged survival has become the goal in the treatment of the hepatocellular carcinoma combined with other cancers. The overall survivals of the liver cancer is relatively low. Before this, Stephen have introduced the 5-year survival of the gastric cancer, colorectal cancer, but we can see it's just similar. It's also lower than the esophageal cancers. It's very poor. And we do think the 5-year survival is superior to the pancreatic cancer. And there are 2 topics for me. The first one is how to achieve long-term survival in Chinese unresectable hepatocellular carcinoma. How to achieve long-term survival in HCC. From Chinese perspective, what is the meaning for long-term survival? It's not only longer survival, but has a better quality of life, and we can also have sustained treatment. If for unresectable HCCs, you must need well-preserved liver functions and less discontinuation and more opportunity for subsequent lines treatment for second line and third line and so on. But liver function is a key factor for Chinese patients. For dual immunotherapies, its complementary dual mechanism reshapes the tumor immunomicroenvironment and laying the foundation for the long-term survival. As we all know, CTLA-4 plus the PD-1 or PD-L1 is different mechanism from the cancer cell or T cells. What is preferred? We all know PD-1 and CTLA-4 is all focused on the T cells, and PD-L1 and CTLA-4 focus on the T cells and the tumor cells. And Himalaya is just reached by the AstraZeneca, the first phase 3 dual immunotherapies trial to significantly improve overall survival for unresectable hepatocellular. Nearly 20% of the overall survival rate. Now we launched the 6-year overall survival. Stephen also said is about 70%. Yeah, and stretch shows superior efficacy, especially in HBV subgroup, suggesting the regimen is well suitable for HBV-related ACC in China. And most of the Chinese patients have the HBV infection history. Nearly 70 to 80% of the ACC in China has HBV infection history. Overall survival was improved with stretch with sorafenib in HBV subgroup reduced the risk of the death. And is the best reported outcomes in China in Chinese unresectable ACC. And we all know the nearly 30 months overall survival also in Hong Kong and the Taiwanese. Yeah. Tremendous and Himalaya studies mutually reinforce OR in China mainland population reached 34%. And OS data immature but shows promising results. We just waiting for the OS data to reach out. Maybe have the surprise for all of us. And Himalaya record strike significantly improves the overall health status, and he shows significant improved in patient-centered quality of life, physician, physical function, and role function as the first-line treatment for the unresectable hepatocellular carcinoma. And the overall tolerance is very important. It's favorable and with manageable and controllable advanced events, and good treatment persistence is very important for the late-stage ACC. And the most AEs with stretch are mild and do not impact the treatment persistence, survival benefits. It's very important. It's not similar as the TKI or TKI plus the immunocheckpoint inhibitor. And stretch users a new area of long-term survival for the patients in China. In the left line, we can see longer survival. It's already reached 20% 5-year overall survival rate, and median overall survival in Hong Kong and Taiwan nearly 30 months, and superior effects in the HPV-infected HCC patients. And at the same time, it also have the better quality of life with nearly 80% grade 3 or 4 TRAE for strike, and most common TRAEs are mild and controllable. It's very important, and it can significant improvement of the quality of life, physical functioning, and rolling function. The liver toxicity is not a concern, and we can say TRAs lead to discontinuation is a small part. It's less than 6%. So early application of the STRIDE for long-term survival benefits in the area of dual immunotherapy is very eager for mainland of China, I do think. And the second is exploring long-term survival strategy in HCC based on dual immunotherapy. And TACE, we all know, is widely used and serves an important treatment in the intermediate and the late stage of the HCC patients. More than 60% use the TACE in China. TACE is widely used in China, and based on CNIOC stage, from the 1B to 3B, more than half of the HCC patients received local interventional therapy. Mostly it is now some increase of the HEC. A pilot study, TACE plus the STRIDE is safe and feasible in BCLC, B and C, HCC. We all know this trial. For the time, we do not introduce exactly. For EMERIT-1, we know EMERIT-1 is the first phase 3 trials of the TACE plus the immunocheckpoint inhibitor and anti-VEGF in unresectable HCC, meets primary endpoint with the near doubling of the median progress-free survival. And this is the EMERIT-3. It's also the first phase 3 study explored TACE plus STRIDE and the target therapy we call TKI, and we just is highly anticipate good results. And there's also some ongoing study exploring the STRIDE combination regimen, and we can see it can plus the target therapy plus the TRE E90 and plus HEC and target therapy also have the advanced radiation pro-beam plus the STRIDE, but this is a small size trial for pro-beam with that. And for the future perspective of the HCC treatment in China, we can see it will be lead with STRIDE as a backstone treatment, and we plus some kinds of the regimen and some kinds of the treatment locally, especially for locally treatment. So what is the conclusion? We can see complex clinical profiles in China unresectable HCC, and we know they have the higher HPV infection rate, high tumor burdens, and poor liver functions. So we should select dual immunotherapies, and it also have the validated stretch benefit. I should close quickly. Quickly. The further perspective, we should starting with the stretch and then advising around the biomarker. They still have any biomarker for the patients at a lot of conference. Which one should select dual immuno checkpoint inhibitor? Which one should which one should select TKI? There's no biomarker at all. So there's a long way for us to get a long time survival for ACC. Thank you.
Thank you, Professor Lian Xin, to give us a very beautiful summary of the treatment with IO plus IO, and especially you present some experience from Chinese doctors using combination of this IO plus IO with local regional therapies. I totally agree with you. IO plus IO need combination with other type of systemic therapy or local regional therapy, especially at the beginning of this treatment. And the second one is the selection of patients, but we don't have any answers. We know some black name list. Some patients should not receive atezolizumab or TKI because of some problems. But someone should receive IO plus IO. We don't have answers. So I believe collaborations with scientists or investigators from clinicals, we will have some answers in the near future. Thank you very much.
Yes, thank you. In China, we all know only 9DW gets approved by the government. They're still on the way.
So can I comment something?
Long? Yeah.
Yeah. So, no, I have two comments. One, I mean, you show the data of hepatitis B, but if you check, in reality, durvalumab works throughout. Of course, works in hepatitis B, but in hepatitis C, what happens is that sorafenib works better.
Yeah.
And this is something that we demonstrate in an individual meta-analysis years ago with the SHARP and Asia Pacific, that hepatitis C is a predictor of response to sorafenib, and that's why. So in hepatitis B, certainly the STRIDE is a good regime. I want to comment also about the arthemide. You were talking about combinations. So you are familiar with the arthemide trial sponsored by Astra. So this is 4 combinations. It's a bispecific in which you are combining CTLA-4, anti-TIGIT, Durva, and Lemba. This is the combination that now is coming into phase 3. The trial is active, and I think also it will be very important. There are not so many trials in frontline internationally, and this is a very important trial. And also, you mentioned, because with Emerald 1, you have progression-free survival, but let's see what happens in terms of regulatory. But you have Emerald 3 that is much more potent, also incorporating lenvatinib. So these are 2 trials that are now in frontline, in intermediate, and in advanced that may add additional value to what we have now.
Yeah, thank you. We do hope they'll have the good results reach out in near future. Yeah.
Thank you, professors. Next, let me invite Professor Dan to introduce next speakers.
Okay, thank you. Let's welcome Professor Zhipeng to next topic. Professor Zhipeng, MD, PhD, Chief Physician and Associate Professor of the Department of GI, Peking University Cancer Hospital. The topic is about gifts to gastric cancer patients from ESMO. Welcome.
Okay, thank you. for Professor Cao's introduction. And now today we will talk about the long-term survival of GI oncology. In this room, I can say that most of the doctors are focused on HCC, but in GI oncology, for gastric cancer, I think now is lot good than the HCC, but also for the BTC and the PC, maybe is lower benefit from the lower survival, long-term survival rate. And I'm a medical oncologist in Department of GI Oncology, and I will in outpatient I will treat HCC, PC, BDC, and also gastric cancer and colorectal cancer. And in our department, I will focus on gastric cancer, and for the clinical trial and the compared with another type of cancer, I also asked my colleague, can you say which patient can benefit from the treatment, and which patient can have the long-term survival, especially for the HCC. But maybe you cannot choose which one will have the very long survival. But for the gastric cancer, if you give me 100 patients, I can tell you which one will have the long-term survival because of the biomarker. So in the whole, maybe gastric cancer is not better than the HCC, but for the gastric cancer, we can choose which one can have the long-term survival. So it's very interesting. Today I will give you the two parts, and the first is the current status of treatment and guideline recommendations. And for China, we can see that most of the patients will come from Asia, and half of the patients will come from China. But in China, compared with Japan and Korea, China has more patients with advanced or locally advanced gastric cancer. And now for the guideline of Cisco, we can see that for the locally advanced gastric cancer, we have the result clinical trial, and we can see that we use the cells for the perioperative treatment. And now today yesterday, we can see that Medhorn, we can use the flout plus PD-L1 antibody and can benefit from the immunotherapy. And for the first line, we can see that there are lots of biomarkers, but maybe in the next year, the biomarker will increase. And for first is DMMI high, and this only 5 to 10% gastric cancer is DMMI high, but this part of gastric cancer can have very long-term survival. And also we can say that we have the HER2 positive, and also we can use in the Claudin 80.2 antibody. And also in China, we have the different guideline for the ESMO or the ASCO, because we can say that we have another certain type of gastric cancer, such as ALP producing gastric cancer, and also we have some peritoneal metastasis. And for the second line therapy and the third line and above treatment, we have more drug than Europe or the America. Yesterday, one professor gives the comments of the three topics. He says that if his patient has gastric cancer, he wishes he will be treated in China. I think because in China we have more drug to treat gastric cancer. And in HER2 positive gastric cancer is better than the HER2 negative patients. But however, from 5 years ago, we can see that the only antibody for HER2 is trastuzumab. But for the TACT clinical trial, we can now see that the trastuzumab cross-line therapy showed a low benefit in OS or the PFS. So in these days, we can say that the 2025 ESMO, there are new treatment paradigm. We can see some, we are focused on, we can say that there are lead break is 5. We can say that also we have the new drug and the new combination treatment. And also we have the median oral and the, we can say that we have the, such as the new drug and the, also we can say that the advanced, locally advanced gastric cancer for the HER2 positive gastric cancer. Today I will give you the 5 clinical trial, and the first is MEDHORN. MEDHORN is first phase 3 clinical trial and using chemotherapy plus immunotherapy. We can say that, but however, MEDHORN do not enroll the Chinese patient, so it will not approved in China government in recent years. And we can say that using immunotherapy for the locally advanced gastric cancer, durvalumab plus FLAUT, we can say that the long-term survival, we can say that not only for the EFS, but also for the OS and also the PCR rate. We can say that if you give me 100 patients, 20 patients will got the PCR. So maybe in the future, some of the patients will not got the surgery. And we can also say that in this year's ESMO, and we can say that the OS was also seen with immunotherapy plus chemotherapy. And we can say that for the three-year OS rate, 70% of patients were survived. And we can say that if the patient is got the PCR, maybe 90% of the patients were not relapsed. And also we can say that the EFS was also improved using immunotherapy plus FLAUT. And the second clinical trial is DG04. DG04 is HER2 ADC is named TDXD. We can say that TDXD confirmed a significant OS benefit over ramucirumab plus paclitaxel with a median OS of more than 1 year. This is a second-line clinical trial. And in this year's ESMO, we can say that the low safety signals was occurred, and for the DG06, this trial is a bridge clinical trial in China. And we can say that for the third line HER2 positive gastric cancer, the OR nearly 30%, and the PFS by ICR was 5 months, and the sensitivity analysis showed a median OS over 1 year for the third line HER2 positive gastric cancer. We can say that in China we have many new drugs. For the DG06, we can say that nearly 20% of patients have received another anti-HER2 drug, including the ADC or the bispecific antibody. We can also say that for these patients can also benefit from the TDXD treatment. In this year, we have another new drug in China named KIN-026. Is a bispecific antibody for HER2. We can say that in the second line, KIN-026 plus chemotherapy significantly improved PFS, lowered the risk of disease progression. We can say that the median OS nearly 20 months for the second line HER2 positive gastric cancer, and the controlled arm is less than 1 year. So the HR is very low, nearly 0.3. And the last maybe it will presented next day. So we do not know the specific data, and we were in maybe several months ago, they say that is a positive clinical trial. So for gastric cancer, we will also have another biomarker, FGFR2b, maybe. So in the first line, we have so many drugs. We can use the chemotherapy plus immunotherapy for PD-1 or PD-L1 or PD-1 or CTLA-4 antibody, or the Claudin 80.2 or FGFR2b, and etc. So for gastric cancer, we can say that maybe now in the whole patient is less than the HCC, but if we choose biomarker, we can say that many patients can have a very long term survival. So this is my presentation. Thank you.
Thank you very much to Professor Zhipeng. From the topic, we know about the very impressive improvement in gastric cancer, especially in ESMO 2025 conference. So I'm very interested in the matter home because before we know the EFS benefit, but nowadays we know the OS benefit. So how do you think about the OS benefit from the clinical trial? Durvalumab plus FLOT demonstrated the prolonged OS when compared with FLOT chemotherapy, regardless of PD-L1 expression, regardless of other biomarkers, so subgroups. So how do you think the OS benefit? Thank you.
Yes, we can see the data. The OS rate improved is less than the EFS, because in gastric cancer, I think is a very heterogeneous disease. Why? I'll give you a patient. Maybe he is DMMS high, so this patient will have PCR, have a very high rate, but this patient will do not relapse if you do not use the immunotherapy. So I think for Metal, I think is also absolutely is a positive clinical trial, and will change the clinical practice in ESMO, in ASCO. But I have said that in China, he did not enroll the patient in China. So in China, we have another clinical trial using PD-1 plus South. So it's also a positive clinical trial. So for the Metal, I think it will change the clinical trial, clinical practice. But for the in China, we cannot have the will be approved by the Chinese government. So I think is. But for EFS and OS, I think is good, and I will use immunotherapy plus chemotherapy in my clinical practice. Yeah.
Okay, thank you. That's a very successful clinical trial, and we are looking forward to the Chinese clinical trial. So the second question, when we talked about the Matterhorn clinical trial, we always compared it to Keynote 585 because it is negative results. So how do you think about the difference? Thank you.
Yes, there are several aspects of difference, because first is different chemotherapy. And but I think maybe you can see the survival curve of the Keynote 585. Added immunotherapy is also the curve is also better than the for the chemotherapy alone. So I think for gastric cancer, immunotherapy used in the locally advanced gastric cancer is from these two phase 3 clinical trial. I think it can benefit. but only a very little patient truly benefit from the immunotherapy. So I think this is a future need where our doctors to our company to combine to find which patients can benefit from the immunotherapy plus chemotherapy in the locally advanced gastric cancer.
Okay, thank you. Many thanks.
Thank you, professors. Please wait a moment. We're going to prepare for chairs.
Join the discussion session, Professor Zhiming Geng, Professor Li Qing, Professor Guang Tan, and Professor Hou Bao. I just make some brief introduction. Professor Zhiming Geng is from the Xi'an Jiaotong University. Hou Bao is from Zhongshan Hospital, and Guang Tan from the Dalian Medical University, and another professor is from the, I think the, so because our time is limited, so we only short discussion is appreciated. So the Professor Zhiming Geng and Professor Li Qing just want you to discuss a topic about difference and similarity in the treatment of gastrointestinal tumors between China and worldwide.
Okay, first, thanks for Professor Shen's introduction. And it's my great honor to attend this meeting. I'm a surgeon from China. My major is hepatobiliary surgery and focus on the biliary tract cancers. As we know, with the progress of immunotherapy combined with chemotherapy and targeted therapy, the survival of patients with biliary tract cancers has been greatly improved in recent years. So for the topic, basically, I think the model of care, modality, procedures, and the goal of treatment are the same between China and worldwide. However, compared with Western countries, there are several differences in China. First, I think my clinical practice, many patients with biliary tract cancers in China are still diagnosed with local advanced or the late stage. So as a result, they often miss the opportunity for curative surgery, leading to a poor outcome. Also, there are certain differences in molecular characteristics and mutation frequencies for biliary tract cancer patients between China and Western countries, and we should pay attention to this point. In addition, the high cost of advanced target and immunotherapy drugs remains a major barrier for the most patients in China because not very rich, cannot afford the cost, so they miss the opportunities for the treatment. So the contributing in quality in treatment access and progress. To address this challenge, several directions are particularly important. First, we should enhance screening and risk-based surveillance among the high-risk populations to increase early-stage diagnosis. And second, for patients with a locally advanced disease, developing effective new advanced treatment strategies can help improve surgical resectability and overall survival. And thirdly, we need to further study molecular mechanics of biliary tract cancers. In short, China is rapidly moving forward to a more precise, integrated, and equitable model of cancer care. Continued collaborations with international colleagues will be key to narrowing the remaining gaps and sharing best practices across the globe. Thank you.
Thanks for the invitation and thanks for the introduction from Professor Shen. And I think there are not really difference between your Western countries and China. And maybe we have different perspectives, but we have one aim that to prolong the survival of the patient. And we learn from each other. For liver transplantation, as example, they not perform the liver transplantation for HCC patients in the early days, but maybe 20 years and 30 years before, in China, we have a lot of liver transplantation for HCC. Maybe there's lots of patients beyond Milan criteria or UCF criteria, but they also have very good results. So nowadays, they perform also liver transplantation, lots of beyond the Milan criteria, maybe sometimes with PPTT. So I think we are still learning from each other, and the advance is still in progress. I think so. Thank you.
So next question is about topic about the clinical practice cases, sharing and multidisciplinary reflection of gastrointestinal tumors. Thank you, Professor Hou Bao.
Dear professors, good evening. Big thanks to Professor Shen for your kind introduction. As a biliary surgeon, my clinical practice and research mainly focuses on biliary diseases, especially the diagnosis and treatment of biliary tumors. Therefore, I would like to share our preliminary experience in the treatment of high-node cholangiocarcinoma with PVE combined with chemotherapy and immunotherapy. High-node cholangiocarcinoma is a highly complex malignant tumor characterized by difficult early diagnosis, low rate of radical resection, and extremely poor prognosis. Therefore, acute pro-operative assessment is very important. For eligible patients, extensive hepatectomy has been demonstrated to improve both the rate of radical resection and 5 years survival. Selective portal embolization (PVE) is a major pro-operative intervention that can induce the atrophy of the right navel and the hypertrophy of the left navel. This is not only increases the successful rate of right hepatectomy, but also helps prevent post-operative naval failure, ensure the safety of the procedure. However, a significant clinical challenge is that some patients have to wait too long time for the left navel to grow, which may lead to tumor progressions and even reduce the chance of radical resection. To address this challenge, we have adapted improved strategy. Administering 2 or 3 courses of chemotherapy, such as GMOX, combined with immune checkpoint inhibitors, such as durvalumab, 对立法单抗 after PVE. This multimodal approach has three effects. First, it provides sufficient time for growth of the neft. Second, it effectively prevents tumor progression. And third, in some cases, it may even cause tumor regression. Overall, this strategy has increased the rate of the radical resection while ensuring the safety of the surgery. To date, we have applied this PVE combined with conversation therapy to 10 patients with high cholangiocarcinoma. We have preliminary results are encouraging. In the future, we will accumulate more cases and conduct more in-depth research. This is my report. My spoken English is not good. Please bear with you.
Perfect.
Thank you.
Okay. Dear Professor Shenpeng and Professor Lianxin Liu and also Professor Lewey and also Professor Katie and Johnson and every colleagues here, good evening. And I'm going to share because the dual immunotherapy is quite important. And I think the Himalaya strategies will be approved in China in the near future. So congratulations. And also, I think according to the last year ESMO, the Himalaya released a 5 years survival rate is 19.6%. 5 years overall survival rate. And this is the only one according to the clinical trials. And also, I think according to the Himalaya data, I think the overall ORR rate is about 34% according to the tremendous clinical trial. And this is equal to the quite similar with the checkmate 90W. And also, I think the Himalaya strategies also have the relatively low TARE, even the IMAE, and this is quite better than the checkmate 90W. So I think it's quite important. This kind of the dual immunotherapy strategies will make a long-term survival for the patients. So I'm not going to share my any long-term survival cases, but I want to show something about the BTC conversion therapy. The BTC conversion therapy, I think this is the first line. The BTC conversion therapy is the immunotherapy combined with chemotherapy. But I think the dual immunotherapy combined with chemical therapy may be promising in the conversion therapy for the BTC patients, because most of BTC patients have the relatively good liver functions, I think. So I think this kind of clinical trials may be helpful and may be promising in the near future. Okay, so that's my opinions. Thanks a lot, Professor Feng.
I'm fully agree with what talk of these four professors, and Zhiming talk about most important things for us is early diagnosis of biliary, not only liver cancer but also biliary cancer. And Professor Wang Jing talk about the advances in liver transplantation. Hobart taught us a lot of technical improvement, particularly for biliary cancer. And Professor Tan told us about how to improve the long-term survival in his own opinion, experience. And I just discuss with Professor Levitt that, and the critical points, just like like the Professor Zhiming, early diagnosis remain the critical important points for prolonged long-term survival, improve long-term survival of Chinese patients, because only 30% of Chinese liver cancer patients at an early stage. And in our country, we had a very good program of HB vaccination, as well as the antivirus treatment. But about half of patients, Chinese HBV infected patients, know they are HBV infected status by themselves. They are one of their HBV infection status. That is why we should improve some techniques of early diagnosis. As well also, the Himalaya is also important because there remain 70% of patients suffering from the advanced diseases. And the straight can give 70.1% of 60 years survival rate. This is very high. So thank you very much for your, because they have, the different perspective to discuss a very important question about how to prolong patient survival. Thank you very much.
Thank you, professors, for your wonderful contribution. Next, let me introduce Professor Qi Cheng from Tongji Hospital to host next discussion session.
Thank you. Today our topic is long-term survival. In our section, I will invite 5 experts to talk about the long survival story. So first is Professor Cao Dayong, come from Beijing. Is Cancer Hospital of China's Academic of Medical Science. The second is Professor Huang Cheng, come from Shanghai. Is Fudan Zhongshan Hospital. So the third one is Professor Ma Ji, come from Chengdu West. Is West China Hospital. So the fourth one is Xun Cheng, come from Nanjing Tianyishan Hospital. The last one is Zhao Yuguang, come from Jilin. The first Bishun Hospital of Jilin Hospital, Jilin University. Welcome. First, Professor Cao, you talk about the long-term.
Thank you. In our daily practice, post-operative recurrence in BDC remains one of the biggest challenges, and the current adjuvant options have limited benefit. Based on our good clinical experience with durvalumab, we explored its combination with S1 as a agent approach. In our phase 2 study, we high risk patients received durvalumab with S1 for 6 months, and followed by durvalumab maintenance. After a median follow-up 10 months, the 6 months PFS was
95% and the 12 months was 75.9% and with good tolerability. This early results suggest that the durable with S1 with S1 can reduce recurrence in the and reduce the recurrence and compare with the standard adjuvant chemotherapy. And we look forward to working with our our partners and after we need to get the long term for the patients. Thank you.
Thank you. Thank you, Professor Cao. Second, welcome Professor Huang to share your opinion.
Yeah, professors. Targeted therapy combined with immunotherapy has ushered a new era in the systemic therapy for HCC. In 2018, we began use tyrosine kinase inhibitors in combination with immune checkpoint inhibitors for advanced HCC. At that time, we have never witnessed such remarkable outcomes in patients of HCC. In the past, we cannot imagine because lots of advanced HCC will be die less than half a year. At that time, we used tyrosine kinase inhibitor and immune checkpoint inhibitors combined treatment for these patients. After 2 months treatment, we can see some of the patients necrosis in the tumor, and especially for the portal vein tumor thrombosis necrosis and hepatic vein tumor thrombosis necrosis. Thus, this breakthrough opened the door for us to explore conversion therapy, considering the possibility of surgical intervention of these patients. To date, in our treatment group, the median overall survival for these patients who have undergone conversion therapy approach has nearly 3 years overall survival, with many achieving long-term survival. A retrospective case of my patients from 2019 January, who presented with a massive tumor in the right liver lobe and a tumor thrombosis extending from the right hepatic vein tumor thrombosis to the inferior vena cava into the right atrium. After 2 months of this treatment, of this combination treatment, the patient successfully underwent liver resection after right hepatectomy and tumor thrombectomy. Adjuvant therapy was continued for 1 year after operation, and these patients till now still alive for about 6 years. So from these patients, we think that immunotherapy opened a new era for the systemic therapies. And now maybe double immune checkpoint inhibitors or triple immune checkpoint inhibitors may be next step for the immunotherapies for these patients. And maybe if these patients had a response for this treatment, maybe still will live long time than before. That's all. Thank you.
Thank you, Professor Huang. Now, please, Professor Ma.
Hello everyone, I'm Ma Ji from West China Hospital. It's a pleasure to share my clinical sites on treatment BTC. In recent years, immunotherapy has made a long-term survival a real possibility for our patients. We've seen numerous cases that are both safe and effective. One case is an 80-year-old patient with BTC. He was treated with durvalumab and GC, achieving over 2 years survival. Thanks to its favorable safety and effective, he tolerated the therapy well and maintained a good quality of life. We look forward to more better treatments to help extend the survival for people with cancer. Thank you.
Thank you, Professor Ma. Please, Professor Xun.
I'm a physician focused on liver cancer, BTC, and pancreatic cancer. And I'm very thankful to being here. And it was a great honor to participate in the Study 22 and the Himalaya, as well as the Tumors 1 study. When we talk about the long-term survival, we naturally remind the IO therapy, because the IO therapy will bring the patient the durable response, especially the IO plus IO. But for long-term survival, we not only to focus on the efficacy, but also the side effects. So I still remember I enrolled my first patient in Study 22. That is the first patient in China, and we are so nervous because we have treated patient with the EP in the previous years, and we witnessed the severe side effects in the clinical study. But fortunately, we didn't see the very severe IRAE in the Study 22 and as well as the Himalaya study. And the patient only experienced very slight diarrhea and got a very good response. So I'm looking forward the STRIDE regimen approved as soon as possible in China. Thank you.
Thank you, Professor Shen. Now last, Professor Zhao, please.
Okay. Thank you to the conference host, Professor Cheng, respected chairman of the conference, and outstanding experts present here. Good evening. It's my great honor to attend this meeting. I was the final discussant, so in order to save time, I will make the long story short. This is a HCC patient with CNLC stage 3B, which is Barcelona stage C. Multiple lesions in the liver, accompanied by multiple abdominal and retroperitoneal lymph nodes metastasis. The first line treatment is PD-1 plus lenvatinib. The patient got partial response, and the relief depth exceeds more than 60%. The first line PFS lasted for 20 months. The second line treatment is regorafenib, but the second line PFS lasted only 3 months with poor tolerance. After that, the patient refused to participate in clinical trial and refused to chemotherapy and refused to IO plus IO immunotherapy. What we should do next? We suggest this patient to TACE to control intrahepatic lesions. But their family members finally chose to do palliative operation. Although the AFP and DCP significantly decreased after this palliative operation, most oncologists and surgeons believe this will not help this patient prolong survival. But after that, we re-challenged the PD-1 plus lenvatinib. As for this patient, the miracle incredibly occurred. We challenged the PD-1 and the lenvatinib. This patient got another third-line PFS more than 3 years. This patient is still under PD-1 and lenvatinib treatment this time, and the total survival more than 6 years. So for this patient, I want to say, there is no right or wrong. Sometimes there is no right or wrong. Guideline is guideline. Practice is practice. Guideline under practice is correct, but individualized treatment surpass beyond guideline is more artistic. So the miracle happens around us. Thank you.
Thank you, Professor Zhao. Thank you. I think the long-term survival is not only a national mission, but also a global goal. So I believe we'll have more and more long-term survival story from China in the future. That's all. Thank you. Thank you, Professor.